Hi, my name is Elena Quintanilla, and today I'm going to talk about orbital hydatid cyst. Definition: hydatid cyst is a parasitic infestation by a tapeworm of the genus Echinococcus. Hydatid cyst Echinococcus granulosus is endemic in the Middle East as well as other parts of the world, including India, Africa, South America, New Zealand, Australia, and Turkey.
Hydatid disease is diagnosed with a combination of radiographic imaging and serologic testing. Ultrasound is widely utilized to screen for hydatid disease given its accessibility, ease of use, and relatively low cost. As a diagnostic modality, it has high sensitivity ranging from 90 to 95%, but its specificity is lower given that it can be difficult to distinguish hydatid cysts from benign cysts, abscesses, and neoplasm. However, presence of hydatid sand, the visualization of the protoscolices within the cysts, would certainly clinch the diagnosis. CT is a study of choice for hydatid disease. Not only does it have higher sensitivity ranging from 95 to 100% compared to ultrasound, but it is also better able to determine the size, number, and location of the cysts. If the etiology of cysts seen on radiographic imaging is uncertain, serologic testing for Echinococcus can confirm the diagnosis. ELISA can detect the presence of antibodies against Echinococcus with both high sensitivity of 94% and specificity of 99%. Based on radiographic imaging, the WHO classification system divides hydatid cysts into 6 different stages to help guide treatment. WHO stage, cystic echinococcosis 1, or CE1, is a unilocular cyst, while cystic echinococcus 2, or CE2, is a multiseptated cyst with daughter cysts. Both of these stages are considered early stages when the parasites are active. WHO stage, cystic echinococcosis CA, or CE3A, and cystic echinococcosis CB, or CE3B, represent cysts with detached membranes and daughter cysts, respectively. These stages are transitional ones between live and dead cysts. WHO stage cystic echinococcosis 4, or CE4, is a cyst with heterogeneous contents, while cystic echinococcosis 5, or CE5, is a solid cyst with a calcified wall. Both of these stages represent dead cysts. This CT image demonstrates a WHO stage CE1 hydatid cyst that is unilocular with an absence of daughter cysts. CT image in the upper left corner shows a WHO stage CE2 cyst that is multiseptated with daughter cysts, as indicated by the arrow. The plain radiographic image in the lower right corner demonstrates WHO stage CE5 dead cysts with calcified walls in the liver. These images demonstrate hydatid cysts in the lung, shown here on the left, and in the brain, shown on the right.
Application in medicine. At a clinical examination, the patient was afebrile and had a pupil mass in the lacrimal fossa. Ocular movements were full. The remaining physical examination resulted wetly normal.
Okay, so hello friends, today our topic is the hydatid cyst. So hydatid cyst is caused by the Echinococcus granulosus. Okay, and it is present inside the liver. So let's see the structure. The identification of histopathological site is totally based on the structure of the hydatid cyst. So this is the hydatid cyst, and these are the layers. So just you have to identify the layers. We draw it again. Okay, so this is the intermediate layer. Okay, and this is the outer layer, and this layer is inner layer. Okay, so now let's label it. So this is the endocyst, also called endocyst, and this intermediate layer is called the intermediate layer, okay, and this layer is called the pericyst or the outer layer. And inside this, sorry, this is the pericyst. Okay, this is the pericyst, and the intermediate layer, this is the intermediate layer, thick mediate layer, and this layer is called the endocyst. Okay, now see another picture. So here it is the inner layer. Inner layer is very thin. Okay, inner layer is very thin. Here it is the inner layer, and these are the intermediate layer. You can see this intermediate layer. Okay, and in this picture also you can see the intermediate thick layer. Okay, and here it is daughter cyst. You can also see a daughter cyst here, and here it is a daughter cyst. Okay, so this was the hydatid cyst. So guys, if you like this video, then please do not forget to hit the like button, and please do subscribe my channel.
Pros and cons. Orbital hydatid are almost invariably located in the superlateral or supermedial angle of the orbit in or close to the muscle cone. Erosion of the orbital roof may occasionally lead to cranial infection. Issue applied in Ecuador. Orbital hydatid is extremely rare to see worldwide, accounting for 1% of all hydatid cysts. In endemic areas, however, orbital hydatid can account for nearly 20% of orbital masses. This orbital disease affects mainly children and young adults. The clinical manifestations include proptosis, as in our patient, mechanical restriction of ocular movement, and visual impairment. Conclusion: orbital hydatid is a rare form of hydatidosis, comprising less than 1% of all hydatid reported. The first choice of treatment for orbital hydatid is surgery. Preoperative diagnostics is important so as to avoid rupture of the cyst and prevent the spread of the parasitic disease.
Treatment of hydatid disease is based on disease stage and cyst size. For inactive cysts, or CE4 through 5, no treatment is necessary and only observation is warranted. For active and transitional cysts without daughter cysts, or CE1 and CE3A, treatment is dependent on the cyst size. Albendazole alone is the only therapy required for cysts under 5 centimeters, while albendazole with puncture, aspiration, injection, and reaspiration, or PAIR, is necessary for cysts greater than 5 centimeters. Albendazole is dosed 10 to 15 milligrams per kilogram per day in 2 divided doses for 1 to 6 months depending on treatment response. PAIR is a percutaneous intervention where the cyst is punctured under ultrasound or CT guidance, its contents aspirated, then injected with a protoscolicidal agent such as 30% saline or 95% ethanol and reaspirated. This process of injection and reaspiration is repeated until no protoscolices are present in the contents of the cyst. Hair has a greater than 95% cure rate in hydatid disease without daughter cysts. For active and transitional disease with daughter cysts, or CE2 and CE3B, treatment involves a combination of albendazole and either modified catheterization or surgery. Modified catheterization is a percutaneous intervention whereby the mother and daughter cysts are removed using a combination of drainage large catheters and aspiration devices. The image on the right demonstrates the surgical resection of a large mother and multiple daughter cysts from the kidney, and the left photo shows multiple resected hydatid cysts.